Hi everyone, my name is Liz O'Riordan and I'm a consultant breast surgeon who had breast cancer when I was 40 and then I had a local recurrence when I was 43. And that experience of being on both sides of the table made me realise how little I knew about what it was like to have breast cancer. Off the back of that, I wrote this book, The Complete Guide to Breast Cancer, How to Feel Empowered and Take Control, because I had so many questions about how to deal with chemotherapy, surgery, radiotherapy, and as a consultant breast surgeon, I didn't have the answers. The only way I got through treatment was by talking to other patients and other patients telling me how they coped and what got them through. And I know how easy it is to get confused, to not understand what's happening, why doctors do what they do to you, and how to cope. So I want to start doing these weekly or fortnightly lives to answer any question you have about breasts and breast cancer in general. You can ask me anything and hopefully I'll be able to help. I've had about 50 or 60 questions put in so far. And I asked you earlier whether you wanted me to do them randomly or in a topic, and I think it was 50-50. So I'm just going to start. And I think one of the things a lot of people asked about is the side effects of the menopause and hot flushes and how do you cope. And I thought by just explaining why we get hot flushes, because I didn't know this until this morning when I actually went to check. I just used to think it's something that happened. This is why. You get a hot flush or a night sweat when estrogen levels in the body drop. And that happens when you go through the menopause naturally, if chemotherapy switches your ovaries off, or if you're given a drug like tamoxifen, anastrozole or letrozole to stop you producing estrogen. Now, when your estrogen levels drop, it affects a tiny part in the brain called the hypothalamus. And the hypothalamus controls your appetite, your body temperature, and your sleep patterns. And that's why all of that is disturbed when you go through the menopause. And the hypothalamus is very important at maintaining your body's temperature. So whether you're very cold outside or it's very hot, your body is at a constant temperature. But the drop in estrogen can give it mixed signals and it gets confused. And it can think that your body is too warm when it's not. Or what it then does is prompt a chain of events to cool the body down. So your blood vessels dilate, the blood flow is increased to the surface of the skin so you can sweat off that extra heat, and your heart rate may go up as your body tries to cool down. So it's simply the drop in estrogen telling a tiny part of your brain that you're too hot when you're not, and that's why we have to flush and we get hot and sweaty and we start stripping off. That was really interesting for me to understand why it actually happens. I'll talk a little about how you cope with hot flushes because they can be soul destroying. The first time I had a night sweat, I thought I'd wet myself because I remember waking up dripping in sweat and I could feel water trickling down my inner bum cheek. And I thought, oh my God, I wet the bed. It was a night sweat and I still get them 6 years on and I'm stripping off and always flushing and it's just awful. Sadly, it is one of the side effects of the menopause. And if we were going through it naturally, we would all get them. And some women suffer much, much more than others. There are things you can do to help, and that's starting with complementary therapies such as acupuncture, reflexology, cognitive behavioural therapy and hypnosis that can all help an awful lot of people. And many cancer centres might offer them. It's worthwhile asking your breast cancer nurses if they know people who can do acupuncture or hypnotherapy to help. The second thing is to control your diet. Often caffeine and alcohol can make things much, much worse. So maybe not having a lot of tea or coffee or red wine last thing at night when you go to bed can also help. The next thing you can try are antidepressants, and your doctor isn't recommending them because they think you're crazy. It's not. They're given at a very low dose and we still don't know exactly why, but they do help control the hot flushes and the night sweats, and they've really, really helped me. As a bonus, they may help the mood swings that you also have with the menopause, but they are not treating your mental health. They are helping with the hot flushes. There's another drug that a doctor may give you called clonidine, which affects your heart rate and helps slow it down and stop you having the hot flushes. HRT is really, really controversial, and there's a reason why it's not routinely offered to women who have estrogen positive breast cancer. And that's because we give you drugs to stop you producing estrogen to reduce the risk of your cancer coming back 5, 10, 20 years down the line. And we know as doctors when it makes you menopausal, it can make you feel like shit and it's horrid. And there is no research done to help the side effects when you can't have HRT. What HRT does is give you extra estrogen and progesterone to help with all the symptoms. And yes, it's great for fixing that and helping with your sex life and improving your bone health. But there is a real risk, and there are studies that have now been done to show it can increase your risk of your breast cancer coming back. And if your breast cancer comes back, it means it's not curable. And the harsh fact is it might kill you. And you have to weigh up that benefit of how bad are my menopausal symptoms, and is it worth me seeking private help from someone who will give me HRT, knowing that it might make my breast cancer come back. And that's why most doctors and nurses who treat breast cancer are very, very reluctant to recommend HRT unless it's a last resort and you've tried all the other things that can help and you're willing to accept the consequences. Theoretically, if you've got triple negative breast cancer and your cancer isn't driven by estrogen, then HRT is safer. But there is always a risk that you could get another breast cancer in the future because you have another breast, and that might be an estrogen positive one. So we're always a little bit reluctant. That's why. And it's up to you to try and make a really sensible, informed choice so you know all the risks. I'm going to go on to a couple of questions now from all you guys that have sent in. So, Sophie Keast asked about mammograms. In the UK, do you get told if your breasts are dense? Well, I think we now do put that on the screening reports, and there's lots of confusion about dense breasts. So, women naturally have dense breasts whilst they're still having periods. And a dense breast means it looks white on a mammogram. As you go through the menopause, your breasts get less dense because you are producing less estrogen, and your breast tissue turns from tissue that could produce milk if you were to have a baby to fatty tissue that no longer has a function. And as your breasts get less dense, they look blacker on a mammogram. And the whole point of mammograms is to see a white cancer on a black background. And if your breasts are very dense, it is much harder to see a cancer. And that's one of the reasons why mammograms aren't offered to women under the age of 50 as part of screening, because we know your breasts are dense and mammograms aren't very accurate. There's nothing you can do about dense breasts. Your breasts are either dense or they're not, and often that's when they feel quite firm and solid. A slip of tea, sorry. But we do know that having dense breasts can increase your risk of getting breast cancer. And it's a small increase. It doesn't mean it's a given. I think that's probably because you have more hormonally active breast tissue and are also harder to feel. Now, interestingly, there is a trial going on at the moment, which you can find on the CRUK website. It's called BRAID, and it's a study comparing breast scans to diagnose early cancer in women with dense breasts. So if you're over 50 and in the screening age, they're looking at doing whole breast ultrasound and MRIs in between the 3 yearly mammograms to see if that helps pick up cancer in women with dense breasts. So you are at a higher risk if you have dense breast tissue. There's nothing you can do to change your breasts, but by exercising and staying healthy, you can lower your risk. Now, Claire Krakova asked, why isn't ultrasound offered as part of the yearly follow-up when the original cancer was not detected on a mammogram? So some cancers aren't seen. They are often lobular cancers, and the reason is ductal cancers they form in clumps, they form in masses that you can see and feel. But lobular cancers tend to grow as sheets. So they're much, much harder to see because they don't form a white lump. And often women can have mammograms that are normal and ultrasounds that are normal, and it's only an MRI that picks it up. However, if you've had treatment for lobular cancer, we know that the hormone tablets you'll have will make your breasts less dense because you've got less estrogen. and mammogram is still the best way of screening. And the reason is this: mammograms after you've had cancer aren't really there to look at local recurrences. They're there to monitor the other breast, because you're at risk of having cancer in both breasts. You are throughout your life, but having had one cancer, your risk is slightly higher of having a cancer in the other breast. We rely on women to check their breasts and look at the skin to look for signs of a local recurrence. So the chances are, if you had another cancer, it would be ductal and not lobular. Another reason why ultrasound isn't used for screening is because it takes a very long time. Screening tests have to be quick and safe and reproducible. So any doctor, any nurse could do the images and they could get looked at and it's reproducible. But an ultrasound is completely dependent on the person holding that probe. And they have to move the probe over the whole breast, going up and down. And then they have to go left to right, making sure they haven't missed anything. And if you've got a large breast, that can take a good 10-20 minutes per breast to do. So that's why ultrasound isn't used as part of a screening tool. Next, I'm going to come on to alcohol, and this is tea, not gin and tonic, so forgive me. Annalie Mabel asked me, what are my views on alcohol consumption for breast cancer? I love this. We know that binge drinking alcohol after the menopause can almost double your risk of breast cancer. Before the menopause, it doesn't really count. And the reason is, before the menopause, your ovaries are producing estrogen in large amounts. But after the menopause, when your ovaries stop working, we all produce a little bit of estrogen. And that is made from an enzyme from our fat. And our fat is converted into estrogen. So this is a boob on my mug. It's from Potts from Scott's, and I've got a mastectomy scar on one side, and it's got a breast to match me, and they did it in blue because it's my favourite colour, apart from yellow. So there, that's the mug. So when we're talking about alcohol, when you drink alcohol, it only gets metabolised to fat. It's not converted to muscle, it's not converted to protein, it only goes to fat. So the more alcohol you drink after the menopause, the more estrogen you can make, which is why it increases the risk of you getting breast cancer after the menopause if you are drinking a lot of alcohol, and that's probably more than 2 units a day. Binge drinking is worse. And if you've had breast cancer and you're menopausal, and yes, you are on your tamoxifen or letrozole, it still increases the risk of recurrence because you're making even more estrogen that those drugs have to stop. However, during chemotherapy in my treatment, I think I drank more champagne than I had in the previous 10 years because there were so many things to celebrate. I finished chemo, I finished surgery. And a glass of bubbly, a gin and tonic every once in a while is absolutely fine. It won't do you any harm. There is nothing you can do to 100% guarantee that your cancer won't come back. It's kind of fate. You can eat healthy most of the time, you can exercise to lower your risk, but we just don't know why it comes back in some people. So alcohol once in a while is absolutely fine, but don't drink a lot of it. Right, this is a question from Abby Barser. It would be really good to know the difference between recurrence and secondary and metastatic. She thought that getting it for a second time meant that it couldn't be cured, but she's seen many posts about women having breast cancer lots of time. What does it all mean? That's a really good question. We're not very good at talking, as doctors, good at talking about recurrence and what to look out for. So let's get things straight. Primary or early breast cancer means a cancer in the breast that may have gone to the lymph nodes in the armpit. And the armpit and the breast are all counted as one unit. So a positive lymph nodes does not mean that it's spread and you can't be cured. That is still potentially curable. But if any cancer is invasive, not DCIS, but a proper breast cancer, it means it has the ability to spread beyond the body. And we assume that there are cells in the body that might have broken on from that breast cancer that are living in your bone marrow or your lymph nodes or your bloodstream. And they're silent, they're by themselves, they haven't found a friend, they can't do anything. And that is why we give you radiotherapy to target the breast, we give you chemotherapy, we give you the hormone blockers to mop up those cells and stop the chance of them waking up. But it doesn't always work because cancer's a sneaky bugger and these cells can develop resistance to the chemotherapy drugs and the hormone blockers. If a cancer is going to come back, it is generally in the first couple of years, or it's 5, 10, 20 years later when you stop the tamoxifen and tamoxifen and letrozole. And there are two ways it can come back. The first, which is actually quite rare and only happens in about 3 to 5% of people, is a local recurrence. And that means that your breast cancer comes back either in the same breast or in the skin next to the scar or in the lymph nodes on that side. So you have your yearly mammograms to look for lumps in the breast. And if you've had breast cancer, you should be looking at the skin, looking for nodules and scars and rashes that look a bit different, because you can still get a local recurrence. And you can get a local recurrence after a mastectomy. That's what happened to me. And it's a bit like this. It's impossible to remove every single breast cell when you remove the breast tissue from the skin. A bit like peeling an orange, you can't remove all the pith from the segment. So there are microscopic cells that can start to grow again. So it's important that you do check yourself. That's a local recurrence. We know sadly that in about a third of women, the breast cancer spreads beyond the breast, and that can come back in your lungs or your bones or your brain. And that is called metastatic or secondary or advanced breast cancer. And it's not necessarily, the most women with recurrent disease are often women who are in their 60s, 70s, 80s and 90s, because they've lived longer for the breast cancer to come back. We know in young women it can be a very aggressive disease and it can come back more quickly, but it is generally the older population that have recurrent disease. If you have a metastatic deposit, for example, in one bone, or a tiny bit in the liver, or a little bit in your lung, there's a chance that a surgeon could remove it, or you could get radiotherapy to treat it, and you may still be cured. And that's called oligometastatic disease, when it's just in one area. But generally, metastatic disease can't be cured, and that's where you will be given either hormone blockers or chemotherapy to try and shrink that disease and stop it growing. Cancer can come back quite quickly. I've seen it come back in a couple of weeks in an old lady who had quite an aggressive cancer. It can be months, it can be years. We can't predict what happens to it, so it's really important to make sure that you do check yourself. You can get cancer in a breast that's already been treated, and I've had patients who had an ER positive cancer and they had a lumpectomy, and then 2 years later they had an ER negative cancer in that breast. It's really, really bad luck, but it can happen. Lisa Madden 21 asked, why aren't reconstructed breasts monitored for reoccurrence? And that's a really good question, because you'd think if you've got an implant or you've had your fat or your back to make a breast, surely that can get a recurrence. The reason is they're not monitored because there isn't any breast tissue there. Mammograms are done purely to screen breast tissue, and after a reconstruction, there isn't any breast tissue left. You cannot have a breast cancer grow in the fat of your tummy because it's tummy fat, not breast fat. You can get an occurrence in the skin. And there's no test to look for that. It's purely you looking at your skin for scars or nodules. And I've done a video on how to check your breasts for that. But that's why you don't get a follow-up. Big Bottom Bev asked about the lymph nodes. Are you more at risk if you have more lymph nodes involved, or you have a cancer in the apical node? And that's the node at the very, very top of the armpit. And the scary but true answer is yes. The more lymph nodes you have involved, the greater your risk for recurrence is. And that's why you may have chemotherapy before your surgery to get the life-saving treatment in first, rather than the surgery to remove the breast cancer. One of the models we use to work out who needs chemotherapy and how long you should stay on hormone blockers is based on the number of lymph nodes that you have. The lymph node surgery is really interesting. I used to think we did lymph node surgery to cure people, but we don't. We remove lymph nodes in your armpit for information, purely to help us find out has it spread and work out what treatment you need. And so we used to remove all the lymph nodes on everybody just to find out, but we realised that was causing a lot of problems, pain, lymphedema, frozen shoulders, which is why we do less and less. And if you have a normal ultrasound of your armpit, you will just have the sentinel lymph node removed. And if you think of your armpit as a pyramid of lymph nodes, the sentinel lymph node is the one at the bottom. And if that doesn't have cancer, We're 90% certain the rest won't. And that's why we're fairly confident we can just do the sentinel lymph node. Now, if you've had chemo first, or your lymph nodes are matted, your surgeon may not know how many were involved. And mine were a bit like that. And it was really frustrating because I wanted to know all that information. But actually, it didn't change my management. I'd had chemotherapy. I didn't need to know it to find out what was going to happen. So if that's you, it's just to try and let it go and trust the surgeons that they do know what they're doing. So whether old Carol asked, my stats for the cancer returning are high, but I'm unsure if that means reoccurrence of the breast cancer specifically or cancer in general. Now, knowing your stats for recurrence is quite a scary thing to deal with. We use a computer model, which is on the NHS Predict website that anyone can look at, and it's based on trials looking at hundreds of thousands of women. And that will tell you what your chance of being alive in 5 or 10 years is, and how that decreases if we add in chemotherapy or Herceptin or hormonal therapy. We assume that everyone has surgery. And when I had a local recurrence, my stats were really scary. I had a 40% chance of being alive in 10 years, and it terrified me. We aim for a 90-95% 10-year survival, and it's really hard to get your head around. What that survival is talking about is your cancer coming back elsewhere in the body. So that's breast cancer coming back in your organs or your bones. It's not any other cancer, and it's not a local recurrence. And I used to fixate on this a lot. And now time is a great healer. I now realise for actually everybody, it's 50-50. Your cancer comes back or it doesn't. There is no way of knowing which of those groups you're in. So by exercising and eating healthily and doing what I can, I'm doing the best I can to put me in the best group. But I can't control that. So Rachel McElroy asked, what is the significance of the ER score? My breast cancer was ER8 and my friend was ER4. How does this impact on hormone therapy? That's a really good question. There is so much information on your pathology form after breast cancer, it's hard to understand. So we test breast cancers for 3 hormone receptors. One is estrogen, which is ER because it came from America. It's why it's not OR. We test for progesterone, and that's like a fail-safe. If the estrogen is positive, then the progesterone should be positive. And then we test for Herceptin, which is a marker on the nucleus of cancer cells. So with estrogen, we grade how positive your cells are from 0 to 8. A triple negative cancer would be 0 for estrogen and 0 for progesterone. And most estrogen sensitive cancers are 8 out of 8, but some are in the middle. They're kind of like a halfway house. And we assume if any breast cancer is even weakly ER positive, say 2, 3, 4, it's worth giving them a hormone blocker like tamoxifen because it might reduce the risk of recurrence. That's what most people think. It's less likely to work because your cancer is only weakly sensitive to estrogen, but we think it's worth a go giving you that. Herceptin is something that's come around in the last couple of years, last 10 to 20 years actually. Before we had drugs like Herceptin, cancers that were sensitive to HER2, and that's the name of the chemical on the nucleus, didn't do as well. Herceptin cancers tended to go to the brain and we didn't have anything to stop them. But with the advent of drugs like Herceptin and Perjeta, we have dramatically turned around the recurrence rate. And people with Herceptin positive cancers often have a really, really good survival. And if they do get recurrence cancer, they can often live for a good 5-10 years because the Herceptin drugs are so powerful. Next question. Claire Nash asked, why are estrogen blockers needed after the menopause? You'd think you don't need them anymore when you don't produce estrogen. But as I said earlier, we all still produce estrogen in our fat. So tamoxifen works by blocking estrogen in breast cancer cells only. And that means you still get protective effects on your bone. It protects the bones, it protects your health. It just stops it in the breast. But because you are absorbing much less estrogen than you would otherwise, that's why you get the menopausal effects. After the menopause, when your ovaries have stopped, we produce it with this enzyme called an aromatase inhibitor. And that's why women after the menopause can either be given tamoxifen or the aromatase inhibitor drugs like anastrozole or letrozole, and they stop that enzyme working. And the reason we give these drugs is to reduce the risk of your cancer coming back. If you had a big cancer, you needed chemo, your lymph nodes were involved, you may get these drugs for 10 years instead of 5. We don't give them any longer, which is quite hard to understand when we know that breast cancer can come back 20 years down the line. Surely we should all be on them for life. Well, we know many women don't take them because they make them feel like shit, and I've thought about throwing mine in the toilet and having treatment breaks because they're horrible. We know about half of women don't take them regularly because the side effects are horrific and there's no research being done to help us cope, so rant over. But these drugs do have side effects. So we know that tamoxifen can increase the risk of getting endometrial cancer. That's cancer of the womb. And if you have it for more than 10 years, that risk can double. And we don't want to take that chance. We also know that tamoxifen can increase the risk of cataracts and strokes. So if someone has heart disease or a lot of medical problems, we won't want to give them tamoxifen, or maybe stop it after a shorter time. When it comes to letrozole and aromatase inhibitors, it's really the bone health that's a problem. They make you osteoporotic. That means they weaken the bones because you're not absorbing estrogen in your bones. So you are more at risk of breaking your hips and your wrists and your ankles if you fall over. And we don't want people to end up in hospital having operations for broken hips. So that's why we stop the letrozole or aromatase after 5 or 10 years. It's to protect your health. I'm going to stop at 1 o'clock, but I've got time for one more question, and I think we can do this again next week. So keep on sending your questions in. So someone has asked, here we go. Are there cases of cancer recurrence in patients who've had a DIEP reconstruction? So a DIEP reconstruction is when we use the fat of the tummy to reconstruct the breast. And you can get a reoccurrence, but it's in the skin of the breast, not the fat tissue itself. And that's why it's really important to keep monitoring yourself to make sure that you know that the skin is healthy. Jane Newman 1 asked, is it true that people get on better with different brands of tamoxifen? Surely they're all the same. I didn't get this as a breast surgeon. I had patients tell me that changing drugs made a difference and I just didn't understand it. And then I really struggled. And a patient came to me on Twitter and said, you should try switching. And I said, really? It worked. And I think it's like this. If you imagine ibuprofen, the traditional drug is that pink coated tablet, but you can get some that are white. They're all different brands. It's a bit like different companies using their own chemical mix to make it theirs. And all the different additives and preservatives that they put with that drug to sell it can have an impact on the side effects. So if you are struggling with the side effects of tamoxifen or letrozole or anastrozole, it's worth asking your pharmacist if they could order you a different brand. It's not the GP and the prescription because they just prescribe the generic drug tamoxifen. But if you go to your pharmacist, your local chemist, and ask them to get you a different brand, it's worth trying it to see if that will help. One more question before we go about bisphosphonates from Alicia Bunjo. Can you tell me about bisphosphonates and why they're being offered? This is a really good question. We know that anyone on Zoladex or a aromatase inhibitor will get weak bones because they're not absorbing estrogen, which puts them at an increased risk of getting bone fractures. And you should have a DEXA scan, which is a bone scan, just to see what your osteoporosis levels are every couple of years on this. As a minimum, everybody should be taking calcium and vitamin D tablets and doing some weight-bearing exercise. That's running, that's speed walking, that's strength training to put the pressure through your bones to get your muscles working, to stop you falling over and breaking your bones, because it can happen. And even if you have metastatic disease, you should still be doing weight-bearing exercise to strengthen your muscles and strengthen your bones. But some of us need extra help, and we're often guided by the DEXA scan to see how weak your bones are compared to someone of your age. Now, the drug we give to improve your bones is called a bisphosphonate. And we used to give them as an oral tablet called alendronate, alendronic acid. And my mum has it because she's got weak bones. And they are horrible. You have to take the tablet sitting upright on an empty stomach. And you have to remain sitting upright for half an hour, not eating or drinking anything. because if you have food or you lie down, it can stick in your esophagus and cause ulcers and make you bleed. But it's a pain in the bum to wake up in the morning, have the tablet and sit bolt upright before you have a cup of tea or coffee or breakfast. People don't like taking them. But they're very, very cheap. They're about 9p. However, there are bisphosphonate infusions like Zometa, denosumab, which you have every 4 or 6 months in the chemotherapy unit as a little half-an-hour infusion that do the job instead of you taking the tablet. But they can have horrid side effects. No one told me about the side effects of Zometa when I went to have mine, and I swear to God, it was like mini chemo. I was shivering, I felt sick, I had bone pain. I just thought, oh my God, why didn't anyone tell me? When I went back again, they said, oh, some people just have a mild cold. Not a mild cold, but the side effects got smaller every infusion I had. So be prepared. The problem with bisphosphonate infusions is that they can affect your jaw. And if you have rotten teeth, they can actually cause part of the jaw to rot. So before you have the bisphosphonate drugs, you have to go to a dentist. You have to get any dental work done to check your teeth are healthy before they give you that drug. So that's why looking after your teeth is really, really important. The half hour has flown by. I really hope this has been helpful. I'm sorry I couldn't answer your questions coming up, but I'll watch the video back and make a note of them. Please send your questions in, and let's do this again in a week or two. Have a great day. Bye.